Good morning from all around the world, and welcome to Structural Heart Like Cases, broadcasting directly from the Cardiac Catheterization Laboratory at the Mount Sinai Hospital in New York City. My name is Pedro Moreno. I'm an interventional cardiologist and a professor of medicine, and I will be your moderator today. We would love to hear from you, so please send us your questions directly from the website or on YouTube. And remember, you can review all our previous structural heart life cases at ccclifecases.org. Let me transfer you now for the cath lab for a very interesting case.
All right. Good morning, Pedro, and good morning to our viewers of CCC Structural Heart Live webcast. And this time, I know it is like kind of not a 1 month. We just did a few weeks ago because of some changes last month. Did an episode on 30th, and now we are here on the 10 days gap. So as you saw it, our gap is a little different. But we'll continue our second Tuesday. Time to time could change. And also you saw the latest new video. I really like it. With that note, we show the interesting case of which we have various types. We try to show all kind of cases. And this is our faculty, which of course myself, Dr. Kini, both are here, and Dr. Tang, and then Amit Huda. He's our Associate Director of Structural Intervention, and the Laracus is on the echo, and you'll hear from him. And fellow-wise, we have Taka. We actually have 3 to 4 fellows, and cardiac anesthesiologist is Dr. Ron Khan. So which require clearly input during these cases, and knowing that more and more cases are being done with a just conscious sedation and a lot of push going on. And we also in next few months we're trying to put a program together. There are simple cases which could be just 30-40% low risk, that we just do it just by anesthesiologist, minimal anesthesia, and that is where the field is ongoing, so that less people in the room and overall overhead of the procedure becomes, decreases. So today we are going to show the transfemoral TAVR with the 29 millimeter Evolut FX plus. This is a 75-year-old patient who had a progressive shortness of breath and had been monitored for aortic stenosis for almost 1 decade, and has some risk factors, had a PCI, which is to the circumflex, which have been fine, but more importantly has developed significant aortic stenosis with a good ejection fraction. Other valvular disease are fine, hemoglobin and all those factors are good. And I'll just ask now to Laracus STEM to tell us about what is going on with the current echocardiogram, which you see where AS and the before patient came into the room.
Yes, thank you, Dr. Sharma. I have here our structural imaging fellow, Dr. Alizande, and also our structural sonographer, Hafizur. As you can see here, parasternal long axis view, normal LVEF function, the aortic valve is thickened, calcified, with decreased leaflet mobility and no pericardial effusion. This is with color, minimal aortic regurgitation, mostly stenosis. And the short axis view of the aortic valve, again, the leaflets calcified, no much motion, and with color also minimal aortic regurgitation. Normal LV and RV function, as you can see here. No much mitral regurgitation. No much tricuspid regurgitation. LVOT measures 2.1. Peak rated that we got here is 4.1 meters per second. Peak greater than 67, mean greater than 42. By the continuity equation, aortic valve area is about 0.6 centimeters square, severe aortic stenosis. Subcostal imaging show no pericardial effusion. So severe AS, high gradient aortic stenosis.
Okay, let's go back to our slide presentation again. Good, very good. Now, echo have been already gone through here, and it's a kind of a pure severe aortic stenosis. No other valvular disease, and even AI is very small. Gilbert, about the findings on the CT?
Yeah, no, CT looks pretty benign anatomy. Annulus is around 25 millimeters, so you can either put a 26 balloon expandable valve or 29 supraannular self-expanding valve here. LVOT is a little bit smaller. Next slide.
Okay.
You can see, plenty of sinuses and STJ. You can see that very high takeoff on the coronary, so coronary access should not be an issue even for a tall valve. Next slide. So you can see here, trileaflet calcific AS. Aortic root angle is actually a little steeper today on the angiogram. We'll show you in a moment, but around close to 60 degrees. Next slide. Access is pretty straightforward here, you can see. So low risk patient. So you can see this is the appropriate size for the
appropriate sizing based on our annular diameter and sinus of valsalva width and height, length and diameter. It fits in for the 29 millimeter Evolut FX plus sizing chart. And so basically that's what our plan is today. Put a FX plus via the right percutaneous femoral axis. Anu, you want to show your aortogram, what you have done so far? Now go to the live now. Yeah, good. Okay.
Patient had a prior circ PCI. Yeah. So this is where we are. Other than the circ stent that you can see, I think we should be able to now cross this valve with the AR2, right?
And this is the cast overlap.
I mean, calcium is there, but just on the leaflet. Yeah.
Looks that.
That's right.
Yep. Okay.
Any questions from the audience so far, Dr. Moreno?
No, just welcome and some messages of welcoming from Iran. Yes, that's
Iran.
it.
Okay, thank you.
Good. And people may be a little surprised also. We started right at 9 o'clock.
That's wonderful.
Yeah, I know. But yes, that's our goal. The goal of 2026, right on time.
Yeah. So you can see that these kind of anatomy, basically any valve, commercial valve platform is, is fine here. I think the key is obviously you want to have the experience, in doing well with your whatever platform that you so choose. And so we, in this case, want to highlight the Medtronic platform here. So we do all three platforms available in the United States, pretty regularly, and we do all of them well. So I think from the audience out there, pick one that you do really well in, but pick a second one just in case the anatomy or access is not suitable, then you can use that one as well.
So one question it says, what about concomitant CAD in TAVI? In other words, doing PCI and TAVI at the same time.
Yeah, so I think what happened is most of the trials of even let's say Notion 3, so all of them actually require PCI just before or after during the same, and then about a few percentage after the hospitalization. That is because majority of them done were outside the United States. In United States, because of the separate DRG and whatever equipment you use, because outside United States everything adds to the bill. Here, whatever you do, the DRG remains of the highest procedure, which is the TAVR valve. So with that DRG, so whatever you do in between, everything is incorporated in it. So practice here in America is that do not do the CAD at the same time. The decision first is whether you need to do the PCI. So that actually has established by various trials with the FIGHT, IV, and of course in the Notion 3, that FFR is a good marker, 0.8 number, and you can see, put the gradient also in one part of the screen, please. Let's show the hemodynamics, 1 second, yeah. So key is that FFR is a good marker, 0.8. In the past we believed that that may not be the right, but it turns out to be FFR. Of course you can do IFR, but yes, a guided PCI is beneficial compared to angio-guided. Second, that yes, PCI if needed, large vessel should be done. Then second question comes when you should do it. I would say this is a various difference of opinion and the practice in outside. Because of the cost, because everything is just at one point, the safe, we do actually very commonly PCI first and the TAVR. Patients are prepared, preloaded. With the clopidogrel, you do the PCI and then you do the TAVR. In America, majority of from TVT registry, the PCI is all majority time either done before, 30 days before, or 1 or 2 months after the TAVR. in the complete TAVR trial, which is ongoing at present with the
No,
balloon
post.
expandable,
I mean, pre.
the PCI is done after the successful deployment of the TAVR valve, and then PCI or no PCI is decided within 24 hours.
Side
If
port
PCI,
action.
then you can do any time you want, but preferred after 1 month, within 1 month. So this is a variation of when it should be done. So therefore, United States, majority of the cases, we do the TAVR first and PCI following. And the decision of the CAD, I think making with the physiological make decision is reasonable and beneficial.
Okay. So we'll say, remember okay. Get with the
So they cross with the AR2, change it to
pigtail.
and which wire we used at this one?
Safari.
Safari wire. And now sometimes you have to put a wire back into the pigtail.
Yeah, I think it's looped.
So we got to teach commissural alignment, very important here
Yeah, this is
because of
Put
the
a wire
CAD, right?
floral, please.
So we brought back the pigtail, but it kind of wrapped around the our delivery sheath of the TAVR, so we needed wire to advance back.
So it says, does PCI first increase TAVI bleeding risk? What about hemodynamic compromise?
Yeah, so that's a question. We always used to believe that TAVI maybe the PCI before, if need, the PCI before may cause more trouble.
Okay, wait. Let us show
The PCI before. Yeah, continue. Okay.
No. Let's go through the steps now.
Yeah.
Because this is
So
the
flash part
question
at
they
3
asked last.
o'clock. Okay, you want to see this is LVEF projection, so we can see the head marker and the outer curve.
Go show the ceiling camera.
So this is to optimize the commissural alignment.
Yeah, they're showing it already. Yeah.
Yeah, good.
Good. And then the fluoroscopy. Look at the hat mark.
Yeah.
Explain.
So
which way it's supposed to look.
the hat marker is on the right side. So you look and see, if I rotate around, see that's the hat marker on the outer curve.
Yeah,
The little
that is a key. So this is in the descending aorta. Keep going.
So the single spine is really nicely tracked along the curvature of the aorta. You can see the head markers in the outer curve as well.
Yeah.
So now we go what we call the cuts overlap view, which we predetermine is usually an aerial caudal projection. And you want to also take the parallax out from the Evolut valve as well as the inflow, and you can see that
Can
this is
you make sure the pigtail has to be in
and the pigtail has the base of the non-cusp.
non.
So Amit right now is positioning there. Counterclocking will get it right down there. So I
Nice.
think it's right there. So a little puff will tell you where we are. So just to give it.
Okay,
So
going
you
again.
can pump
Very
it a
good.
little bit.
Yeah. So you see that this is very
Okay, good.
important.
So
Okay, now we can
we're going to start
start
pacing at 150. We usually just use 2 numbers. Go ahead. Yeah, please. Okay, go. Cine again.
Okay, 180.
Cine.
Still very high.
Yeah. 100. So sometimes it's so dynamic, you might need to pace a little bit faster. Floral, please. I think I might have to push to the outer curve. This is steep.
No, I don't
this,
like
yeah,
it.
this is steep.
Very little calcium also.
Yeah.
So you're looking for a 0 position there?
No.
So yes, you can see very deep on the left, so we have to recapture. So you want to make it in the outer curve. So 150, please. So what we typically do is you have to align the 3 dots. So I would fully recapture here. Okay, because you want to be able to push it to the outer curve. So Dr. Kini will push the wire now to the outer curve. There you go, to send it up a little bit more, maybe even a little bit more.
Now, yes. You
Little bit
see
more.
how it is tilted
push
more
the
on the
wire
outer
more.
curve?
Push the wire more, please.
Okay.
You have to stand it up. Okay. Let's do a quick
180.
cine. Let's do a quick cine while you push the wire. Okay. Push the wire. A little bit higher. Push. Good.
Is the
I think it's okay now.
angle.
Yeah, it's the angle. Okay,
Is the
100.
angle.
Single spine.
Yeah.
Yeah, it's very bad.
Left is still deep.
Let's wait a little bit. Okay. Let's try again. Okay, let's see. We might have to probably have to recapture again. Oh,
No,
it went
no,
deep.
no.
Okay,
You know
no.
what? I would not release this valve.
Okay, yeah, all right.
No, no, not even that. It may move even
Yeah,
afterwards.
yeah.
Change.
While
Okay,
recapturing one question, could you explain more about the
Yeah.
markers? Why it should be on the outer curve?
Not
No, the
markers.
Let's
Not
let's
markers.
recapture up above the.
Okay, let's wait for.
Just wait. Let's regroup for a minute. Okay, back up pacing.
I think it will change to sapien. Not ready.
I agree. So we
are having a discussion here. So you see what happened there as we were trying to deploy, right? See what happened. It's moving up and down, which is not a good sign. Essentially, I think it's trying to tell us there's not enough calcium to anchor, which we already knew the calcium, whatever is there, is more on the leaflet. So we are worried that if we release one, positioning is not right. Even we tried a little bit positioning, go to the outer curve and then try to release it. Even if we release, we are worried this will likely, migrate down.
I have an issue.
You want to go back to the CT scan picture so we understand?
What size is this? What size?
Can you go to the slide? Slides.
Yeah, look at that.
Okay, here, now wait. Not this one. Where is that? Oh.
I guess our audience is concerning a possibility of balloon expandable here.
We are considering that. Yeah, because once you tried it 2 times and this is the most important sign that this is not stable valve to release.
Yeah, that's the
So we
other
are going
question.
back. Yeah, we are going
How
back
many
and seeing the
times?
angle. How many times? You are actually by their a few you can do it 3, maybe max 4. More than that you should not recapture, which we already done twice. So you're probably allowed 3 times because now you already see, if you see at the bottom, right? That you start seeing some unfolding. But that's okay when if we are okay to release, and then when you post dilate, that unfolding disappears. But that's not the thing. We are concerned about releasing and migration of the valve. I don't know, Gilbert is away. He will probably tell us more about the angle. Right?
Yes, a little bit more
Yeah.
horizontal, Dr. Kinney.
More of a horizontal, then that's one. And then look at the, look at that. Very little calcium. Right?
Correct. So it's
Look
like
at
a
this.
watermelon while you're deploying.
Yeah, yeah.
Contrary to the balloon expandable, when it goes into the ventricle, this self-expandable can also dive in too much.
The balloon, no, this will dive in more, huh? Okay. No, this is more likely to migrate down rather than when your balloon expandable. Remember what happens is you are at 180, and at that time you just have to, whatever, in 20 seconds or so, you're deploying the valve. Yeah. I mean, a lot of calcium definitely is supposed to anchor it, but if that doesn't happen, still we're okay. Yeah. So what was the question about the You had a question when we
Yeah.
were discussing about the dots.
Yeah, he wanted to know the relationship between the dots and the whole deployment, specifically the outer curve.
Yeah, so what we said about the outer curve is a hat mark. Hat mark is at the upper portion. You see that? So I don't know if we signate the hat mark.
Yeah, you explained it very nicely in
Yeah,
the
in the when we were going
descending.
up. Yeah.
Yeah.
You see that little ring, that extra ring, that's that hat mark we call. That has
Yes.
to be on the outer curve,
Okay.
so that your commission is well aligned. I mean, aligned to the native valve. That's so. And then in this newer generation valve, you see the big diamonds. You know, those diamonds will be facing the ostia of the coronaries. That is the main reason. So nothing to do with the
Markers.
dots. Yeah,
Yeah.
markers. So let me go back that. I don't think we signate it.
Yeah, you see there. Yeah.
Yeah. You see the head mark? That is that has been the outer curve.
Mm-hmm.
And they always want a cusp overlap view. That way you know. See, we started cusp overlap. You see that?
Yes.
The lower part of the valve, all three dots. At least what they see is 2 dots have to be below the annular plane before you release.
Okay.
Yeah. So we did that. If you see, all 3 are below.
Yes.
But then when you go here, it's at least 2 large diamonds on the left side, and that's a no-no.
Oh.
Yeah,
it's
that's a
pretty
no-no.
Changing it?
Yeah. So one thing that we have been noticing, I think, where did Gilbert go? If Gilbert can explain better, is since they took off the spine, there's a single spine, that we see this kind of a situation that's arising. We tried few times.
No, but what you do is put the pigtail into the ventricle and it'll give you a little better cushion. Where is Gilbert?
Right here.
No, we're
Yeah.
going to.
Yeah. Put the pigtail in the ventricle, it will give you better cushion, and then we slowly will take the pigtail out.
We'll do a
We're gonna
balloon
put in.
expandable valve because, with the more radial force. Let me
And
just
the
go to AP
diameter?
for a minute. And we'll be 26 plus 2.
26 plus 2.
Okay.
So it's
You want to
appropriately
make sure
sized.
it comes out through the sheath without any problem. No,
So
take the
here,
sheath.
when advance the sheet, advance it back in, please, Dr. Sharma. Advance it back in because it's over captured the nose cone. So advance. Yeah.
Yeah. Good.
Okay, so maybe that's better now. Let's see if that works.
Yeah.
There you go.
Nice. So, Dr. Sharma, you increased the heart rate of one of the audience here.
Yeah. Plus 3
He
plus
said-
3 cc.
His heart rate was rising while you do that LV.
The question was, what can we keep it with? But it's
Yeah.
now question is the bigger valve will be the answer or no? Bigger,
No.
bigger self-expanding.
No. No, it's the coaxiality, Dr. Sharma. It's appropriately sized.
No, can
So let
I
me
go
hold it-
back? I
let
went
me
to
hold
the
it.
slide.
me
I was
come.
trying to say, remember, for the audience, what we need
Yes.
to teach is proper selection, right?
Yeah.
So can we go back to the slide?
Blood.
All right.
Good.
Let me hold the groin. Can I get a dry gauze, please?
Dry.
You have to cut that.
Yeah.
Okay.
Each
We'll
sheep
do
is
it
ready,
later,
right?
after the valve.
Can I get a dry gauze, please?
Well, as a moderator, I have to transmit the questions here. STS score 1.
Yeah.
Can surgery be done?
Yes.
Yeah, sure. But same thing, the
What's the
low
wire?
risk
What's the
group,
wire?
Here's the other
whether
sheet.
surgery versus tower is the
Yeah,
let
same
the thing
he's
outcome.
asking.
Yeah. But yeah, surgery can be done, absolutely.
Great. Good. Okay, E sheath, please.
I mean, it's the same situation like as if you are putting the valve in an
Yep.
AI situation, pure AI.
E
Ease up.
E up. E up.
Ease up.
Follow, please. Follow me up.
Yeah.
Follow me up. Good. The wire's in the ventricle. Good.
Yeah.
Okay. I'm holding the sheath. Follow the wire. Watch the wire. Floral, please. Advance the wire, please. Good. Let's do an aorogram to see what's going on. With the repeat capture, I just want to make sure.
Means we haven't.
You always worry about some dissection, staining.
No, just want to look at the root
issues.
anatomy.
Yeah.
That's all. Okay, what's the angle again? What's our LA07, quad 07? So that's why we always do a free cuts view as well. Okay, good. Floral, please. Okay, let's do an aorogram. Ready?
1 sec.
So that's a bit of AI now, I think.
Yeah, that's okay.
Yeah.
We'll just place
Very
the.
little, yeah.
Yeah, that's
26?
26 plus 3. I want to
Yeah,
plus
26 plus 3. No, we did not do a BAV before in this case. Yeah.
Yeah.
3. You okay up there?
Oh, what are the other questions? You said some questions are coming.
Yeah, could you please show the per-close hemostasis at the end?
Okay.
That's the
Yes.
per-close.
Yeah, we'll
Yes,
show that.
we
yeah.
will. Absolutely.
Yeah.
Okay.
Let's get the valve in first.
Can we show the.
And I
Slides,
think
yeah.
the question about the surgery might be related to this case. In other words, would you consider stopping and send the patient for surgery, or you try the balloon expandable?
In
Oh.
this case, I think if a balloon expander can be safely done, so we will go for balloon expander.
We've done that before as well.
Yeah.
Very good.
We
Very
have done
good.
that, yeah. Tell us now.
Pre-procedure planning, is there anything with the angle?
So the
to try-
horizontal root is, it's 56. It looks more horizontal here. We were showing that on the angiogram. If you look at the angiogram, I think, but the key is that the catheter could not be coaxial. This is very important. This is a very important teaching point for this case.
And if you remember, I made the point, the calcium is only on the leaflets.
Yeah.
Yes.
Remember, it's not on the, you saw that, because to me also it looked a little unusual, that all calcium was only on the leaflet and nothing in the annulus and in the aorta. So they see the pure, only on the leaflet. I made that point beforehand, so that was an unusual finding, but we had done those without
Yeah,
any
but I
problem.
think this is really what Dr. Kinney is saying, the telling sign.
Yeah,
This
go
is
to
image.
the fluoro now.
No, go
Go
back
on
to
the
the fluoro.
angiogram.
Yeah, you
So,
want to show it.
so
Yeah.
the
So the-
fact that we deployed, this is our second deployment, okay? And then you can see the valve literally went in, towards ventricular, and it did not really stick.
So okay, let it play. I think we
Yeah,
played
so
this
Dr.
once.
Kinney can explain what she's
Yeah.
what she
So you
meant.
see that we went number one. Normally we deploy it at 150. Okay, the heart rate was high. We needed the blood pressure low. It has to be less than 50. Ideally, you don't want any cardiac output. And as we are releasing, there was a picture. I
No,
thought
there was first,
no.
before.
After that we did.
This is the first.
This is the first. Okay. This one we've seen. We explained it. So here we are trying to release. Okay.
So we try to push the wire to put it out to the outer curve to try to make it more coaxial. And Dr. Kinney was pushing very hard. Obviously, you don't want to push too hard and cause a perforation. But you can see that despite that, it still goes towards the inner curve. And it's not too oversized. This is appropriately, size for the 29 Evolut per sizing chart you saw earlier.
Ready? Okay.
3 plus 3.
Now do it now before you bring it here. 26 plus 3.
There is also a question about balloon valvuloplasty with the true balloon.
Yeah, so we did not pre-balloon for the exact reason, So we
Yeah.
want the calcium to anchor, against the native anatomy. We would typically post-dilate because, to optimize the frame expansion, because it's a low-risk patient. You don't want under-expansion. That's a recipe for the, potentially early degeneration. But yes.
Gilbert, for
Can you
our
hold the one?
audience,
Come on,
I have
come
a
on, come on.
question, like it
Yeah.
will be interest to them. Like this repeated capture or recapture, does it has to do anything with the calcium mobilization at the valve?
So that's a great point, Amit. So, when you recapture multiple times, essentially doing a mechanical BAV. And so the pliability of the valve may reduce, number one, and there might be risk of aortic regurgitation, the Kinney already mentioned, also risk of embolic stroke and so forth. So I think you have to balance all those situations, and this is to our earlier point that you should use whichever platform you're most comfortable with and get the best results with. And this is kind of the situation where yes, we have been doing Evolut now for 20 years here, in Mount Sinai, and sometimes based on the anatomy we can't predict it, and we might still have to do what's best for the situation.
Now, why did you choose a 26 balloon expandable instead of a 29?
Because that's exactly how it's sized by the manufacturer chart. So if you look at every valve, the mean diameter, remember, is 25 point something. So the area is within range for 26. But because since we already did a multiple recapture and deployment of the Evolut, so we would now add more volume to ensure we can anchor appropriately. So we will also do what we call a double tap, maybe even at 1 cc depending on the aortogram after we deploy.
Yeah.
And the key here is to deploy as high as possible, stick against the leaflet.
Yeah.
Don't deploy deep here, okay? So not just because of the anatomy, but also conduction system issues. You don't want, have a pacemaker on this patient. So this is very important. That's why I want to do another aortogram after we've done, multiple deployment to see if there's any potential, damage or things that we see on the aortic root that might, make us more cautious for the deployment here.
Yeah, another question from the audience. Let's assume you don't have another valve. Let's assume you have only this valve. And would you consider a basilica to prevent coronary obstruction?
No, there's no coronary obstruction risk here. The coronaries, remember, they're way high. They are well above, 18, 19 millimeters. So this is not the issue.
Okay.
So it's not a leaflet modification issue in terms of valve deployment with this platform.
No, but let's put it this way.
So,
if there is the only valve available, you can put two valves. Put one just above and put a second one inside. That will have a better chance to stay.
Okay, ready?
Ease up.
Yeah.
Ready?
Okay.
Yeah,
now we are going with the 26 plus 3. And remember, 3 usually does not mean 29. Usually it's a 50%. So it means 27.5.
Beautiful.
Yeah.
Do you have the sizing chart for this valve there on your slides or no?
For Evolut,
I
yes,
can
not
on the
the
other slide, we can put it there.
Hey,
But it will not fit into this criteria at this time.
It says, what about a GINA valve for this situation?
That is it. That's it if you have it. Yeah.
But that's more for pure AR, right?
Yeah,
so
but this is still, I would call
some
this one is a pure AI type situation.
Yeah, so
but
you
GINA
can
valve
also
will be the good one here. Does not need any calcium. Only problem is right now they are orphan because Edward was supposed to take over, but because of the federal rules regulation, they have pulled the plug. So now they are independent, and they need to be some company had to acquire them before it can come to the market. So that's a very good chance that valve will be available soon, but they don't have a taker because the company is not big enough.
Can we decrease the heart rate a little bit, Dr. Ramkhan? Can we decrease the heart rate a little bit? Yes, yes.
Should you stay in
drip?
Should you stay in that sinus for the balloon expandable?
Yes.
Yeah. Let them circulate the esmolol a little bit.
Are we paced at 100 now?
Too many PVCs also. Yeah. What do you think? You like it?
It's good.
Another question. TE will help here?
No.
No. One. What do you want? 180. Inject. Okay.
Can we do 200 or no with that pacer?
No.
Back up.
Can we wait
If
with
there is a pacer, we can get to 200.
Yeah, but we don't carry it. He's giving esmolol is going in, right?
Yeah, we just lower the blood pressure. Oh, this is still pacing? No, off, pace off.
So it says this is a 26 plus 3, correct?
That's right.
That's correct, yeah.
That answered the question. Could you also explain positioning of the balloon expandable valve?
So in this case, you want to look at the top of the frame because the top does not foreshorten much in the S3. The balloon marker should be 1 marker depth, length, above the annulus. You can see that here. So that's kind of roughly where we are.
Or a 2/3, 1/3,
yeah.
whatever.
So you can see also they call the loosen line.
So you see what he's trying to say. You see the center of the balloon, right? There's a marker.
Correct. Yeah.
So one marker below that, which should be the annulus.
I don't know if they listen to me, but
This is,
Told
you
me.
understand? Yeah.
we started
Okay.
Hopefully one day there'll be
20 years ago.
some kind of a fluoroscopy device that tell you how to
200?
place it.
Okay, ready?
Okay, good. Now we are good. Everything is okay. Okay, 200 now. So we gave a little esmolol
or go?
infusion to decrease the heart rate and
Test
blood
or go?
pressure. No, test.
Okay, Sine?
Not
Inject.
yet. Okay, go.
Good. Off? Good. Yeah.
I did not get to see the blood pressure.
No, it was all over the place.
Yeah.
Okay.
Everybody happy there?
Yeah.
Yeah. Okay.
Okay.
Now
long
we are
pacing run.
deploying. Okay, 180.
200. Good.
Oh, it's going to 200?
Good. Go.
good.
200. Yep.
Very good.
Blood pressure is low.
Good. All the way.
Very nice.
Sine?
Take the pigtail out now.
1 second, Dr. Shah.
It's going to move otherwise.
Okay. Keep pacing. 150. 100.
Get us a J wire.
100. Back up. Good. So we know we had a high implant based on the pigtail marker reference. And you can see it foreshortened very nicely from the ventricular side, no parallax on this valve.
So that's why you kept the pigtail there during the whole expansion?
Yeah, we do that for pure AR as well, right? So this is now more like a mixed AS-AR etiology. So you have to have some reference marker. If you have a lot of calcium in the root and the annulus, and then you don't need to, or you have like a stents or STJ calcium. But in this case, absolutely. And we actually would double tap this as well. So but first we'll do an
But before
aortogram.
that, we are going to remove the pigtail.
Yeah, and then we'll do an
And
aortogram.
in a situation like this, I used J wire.
Yeah, you have to use a wire exchange. You cannot just pull it.
Yeah.
Very important. Okay, go.
Okay, ready?
Nailed it. Okay, good.
Yeah.
All right.
Nice.
So,
Yeah.
okay.
You want
So
to
let
have
me
one
show
more
you.
CC?
No,
Okay,
Dr.
no,
Shah,
I just
think-
want to show you
Yeah.
how you remove the pigtail. You see that with the J wire?
Yes.
Slow. Advance the wire a little bit. You see that
Yeah,
with the
because you
wire?
don't. Yeah, Dr. Kinney is trying to show you that don't have the hook of the pigtail. We'll hook
That's
them
it.
out. Okay, let's flex and go in.
Okay, good.
Okay, we'll do one more inflation, guys. Okay, good.
The audience is sending several clap signs here.
Good.
Okay, 200.
Okay.
Long pacing one again, Dr. Khan.
200.
Is it capturing? No. No, it's capped. It's not capturing.
Blood pressure is still high. yeah.
No.
Now
Oh,
it's
there we go,
coming
there
up.
we
Yeah.
go.
Nice.
Go.
Yeah, good. Yeah.
Quick, Dr. Shah.
Yay.
Now we got it. You see that?
Yep. Keep pacing.
Keep pacing. Keep pacing. Yeah.
Okay,
We're going
back
to
up.
show the
Yeah.
hemodynamics.
Pigtail now.
Pigtail.
Slow pigtail.
Leave the wire.
Yeah.
Let's back out.
And then
back
show
up,
it
please,
what you
back up.
wanted to show. Give me 5
Floral,
minutes
please,
or something
floral,
on my
please.
side.
Fix it.
Okay, advance the wire, please. Submit.
Yeah.
A little
Yeah.
bit more.
We can show the closure after
Yes,
this.
we'll show
I'm
the
going to
closure because
show
very
the-
important. Because remember, the 18 French gore is 20 OD. We intentionally here use a 16 French E sheath. So 16 French E sheath is a little bit bigger, so you can get some hemostasis rather than a 14 French E sheath. It also allows you to track the 26 system a little bit better.
Okay.
Okay, so once we have the pigtail, we'll have Sam and Layla and Hafiz look at the echo. Just give us one moment. Okay? Floral, please. Yep.
Go. Yeah.
Good. And then we'll use a JY to exchange this afterwards. Okay, good. All right, let's do some hemos. And Layla and Hafiz, please do the echo.
1 second. Wait. Let me take it
Yeah.
out. Otherwise,
Go
there's
ahead.
a few
Yeah.
RBCs.
Anu, why do you insist in keeping pacing after balloon deflation and pulling?
Yeah. So there have been cases when you're trying to, you have a deflated balloon, some of it could be winged. You don't see it on the fluoroscopy, and there could be mobilization of the valve. Okay, that's number one. Number two, here, we know there's not a lot of calcium in the annulus. So you got to be 300% sure that the balloon is completely deflated. You have the valve expanded, the balloon is completely deflated. When it is spacing, there's nothing else. So you remove it out, and now you know the valve is completely stable by itself there.
Okay.
Fantastic.
Yeah, Dr. Kinney is
explanation.
absolutely right. Meticulous exchange is the key. You have to wait for the balloon to completely deflate. And even if you do, remember, there's still a little bit of remnant of the fabric in there that might not be visible in contrast. You have to pay double attention before you withdraw the system. If you do not let the balloon completely deflate, especially the larger valve, the more volume in the balloon, you can risk embolization by dragging the valve out. And that has happened before. So this is extremely important, especially the native anatomy does not have a lot of calcium. So in this case, you can see on the CT, there was not a lot of leaflet calcium. There's certainly no annular calcium. So it's not like a really hostile, densely calcific AS. So you have to be super careful. And in patients with mixed AS-AL, you absolutely have to follow very strict protocol like what we've done here in terms of exchanges. So now, we are
Show
not
the
going to
Yeah,
hemos-
what
the
about the
detail.
echo? Echo, we're
How does
asking.
that? Can we
No,
show echo
one-
live? Yeah, echo,
Beautiful.
please.
Yeah.
Yeah,
Stan, please
yeah,
comment.
Yeah, echo looks great. This subcostal imaging, let's put the contrast color there. Yeah. No pericardial effusion, no PVL from subcostal. This is the valve. Okay, let's go apical.
So the key is to make sure we haven't caused any acute issues here, right? Because of the recapture and so forth, and then putting a second
Color,
valve. So
color.
that's, and remember, this is a low surgical risk patient. So this
no
patient could have gone
PVL,
for surgery, as we mentioned
no
before. So we
PVL,
want
no
a
valvular
perfect
AI,
result here.
gradient,
So,
mesogradient. Yeah.
And I think Dr. Ankhan's esmolol
about
infusion
6.
has done a great job. He's
That's
stabilized
right.
now.
Absolutely. Because the patient, you can see a very hyperdynamic LV.
Yeah.
So again, anesthesiologist, your friend. I know we all like to do it without our team here, but we have our team, and that's also
Great job.
speak
Great
to
job.
our excellent outcomes to our
Dr.
program.
Stulin.
And anesthesiologists, our partners, like kind of hand in glove. So they
Great
can
job, bro. Great
help
job.
or hurt. So this is
Okay,
very
let's do
important.
the hemodynamics. Show the hemodynamics.
Yeah,
Beauty.
right there.
Yeah, and then we can show you the closure. That's the number one. I think the learning point here today was, for us, understanding, both me and Gilbert were looking at each other when this happened the second time. You see that? This was telling us that this is not the right valve in the situation here. Agreed, Gilbert?
Yeah, this is not a stable situation.
Yeah.
Great decision on you guys to realize and change the valve. Unbelievable.
Yeah.
Okay.
Yeah.
All right.
Okay.
So
Now
I think
we can show the ceiling cameras.
Yeah.
They're going to go through because that's what they want to watch, right? Okay. You know what? One fluoroscopy
yeah.
guided.
And then we'll wait for Dr. Sharma to come
Yeah.
Okay. Good.
with the.
Yeah.
Any questions, Dr. Moreno, from the audience?
Yeah, the last one. Well, there was one question during the deployment, and it says, how can we change the position of the HAT marker?
Yeah. So you don't want to change it when you are across the annulus. You only want to change the hat marker orientation in the descending aorta. Otherwise, you'll risk aortic dissection.
Yeah.
Okay.
So with the FX system, FX Plus, there's only one spine. So you can freely rotate the descending aorta with the hat marker in the inner curve or outer curve. But, the thing is that once you cross the arch into the ascending, you can no longer rotate it. It's against the IFU. It's risk aortic dissection. So if you, by mistake, have the hat marker the inner curve, when you cross, the safest way is not to rotate that there. Bring it back all the way to the descending aorta, rotate it in the LAO projection. Do it, with the rotation. To the satisfying angle, which is the outer curve. And then
We lost you.
drive it back to
We lost the audio. We lost your audio, Dr. Gilbert.
Okay. Now hold on. If you can
Yep.
see the ceiling camera.
Yeah, the ceiling camera is good. Yeah.
Okay. So
We're
they're going to
watching.
go through the steps. You see that? they have put the introducer back in. The pre-close was already there. So pre-close is at a certain angle, 2 o'clock and
10
right,
o'clock.
10 o'clock. You see that? You see it at 2 o'clock,
Yeah,
10 o'clock
2
of the
o'clock
clock.
and 10 o'clock.
Yeah.
Yeah.
Yeah, two
And,
pre-close that were done.
If there is no issues, then we usually try to partially reverse the heparin also. So we ask our colleagues to give 40 of protamine. But like there are certain cases who are high risk for thrombosis. So like if somebody has a AFib and prior stroke, then we usually don't reverse even partially sometimes. And we use the dilator in.
They're in which room?
Sheath
Room
was flushed. Those are the good practices. And now our fellow Taka gonna take out the sheath, and I am gonna pull on the 10 o'clock, which we deployed first, and then we're gonna pull on the 2 o'clock so that the knot can go in. Okay, Taka, let's walk out the sheath. You watch here, I have to go 2 minutes.
So you can see we always like to put the dilator back in because dilator provide you the support and stiffness. And so, and also in case you need to do an angiogram, let's say you're concerned about iliac and integrity, just pull back the sheath and the dilator a little bit, and then you can do you can sequentially walk it out like what Amit is doing. Okay, in this case, obviously the axis is straightforward, but in hostile anatomy, this is a lifesaver. So never throw away the dilator. That dilator is a friend, especially in very tortuous anatomy. Remember, sometimes with the iliac bands, if you pull it out, there's an inseam now with the expandable sheath, right, the E sheath, that can cause it to get caught in the calcium wall. So by having a dilator, you get an extra support to allow you to help with that. So Amit can tell you the rest of the.
So we use the knot pusher to further make the knot go further down on both sides sequentially, and you can see there is hardly little bit ooze, which is likely the track ooze. Now at this moment, we're gonna take out the wire, and then we're gonna start locking our percloses.
So Amit, tell us about your protamine strategy. How much protamine you give in these cases?
So we
versus heparin?
Yes, so we usually partially reverse it unless there is a compelling reason. If somebody has prior history of ischemic strokes with large Chadwick score with the AFib, then we try to avoid even the partial reversal. But in this case, there was no such any indication, so we partially reversed it using 40 of protamine because our ACT was more than 400 to begin with.
Yeah, so our target ACT is typically 250 to 300. In patient at risk, typically more towards 300, but over 250 is typically sufficient. But certainly, you have to be mindful what your actual final ACT is before you decide how much to reverse.
And as you can see, we locked both the percloses now. We cut it down, and the axis looks good.
Excellent, beautiful demonstration. Very nice.
So while we wait, any questions from the audience, Dr. Moreno?
We have 29 total questions today, and the last one is genius decision, and the clap sign as well as the thanks sign from our friends from Iran specifically. Thank you so much.
Yeah, but Dr. Moreno, I think this case really, even though it looks straightforward, you need to, that's why I understand more than one platform, right? You cannot just try to use only one platform exclusively. All the different platforms have their, pluses and minuses. So I think, you do need to know both self-expanding and balloon expandable platform, I think, as a TAVR operator, as Dr. Keeney has, taught us all these years, and also in today's case, especially to have that judgment. And Dr. Keeney can elaborate on the teaching points here as a master teacher. So.
Yeah, what other questions were there? I know you said 29 questions.
Yeah, I think we answered all of them. They were so fast, and during the deployment we have so many. Yeah, but yeah, Anu, I think the decision was the key here, huh?
Yeah. I know Dr. Sharma was trying to explain that we can use another technique to anchor it using a pigtail, a wire. This patient is low risk. I don't think that we should try to do that when we know there's another option that's possible, and we showed it. changing the valve, and the situation was
Yeah,
good.
and like I said, we always tell our patients, right? We can do a lot of complex interventions, but we cannot change the person's anatomy. In this case, the anatomy is shown to be unfortunately not favorable to the Evolut platform, despite Dr. Kinney pushing the wire, we recapture, we try to stand to the outer curve, and despite all of that, we still did not have a stable anchoring at 80%, because 80% is the point of no recapture and no return. So you have to make the decision right there what to do with the valve. And the fact that after we do that, we were pacing to offset the pulsatility, it start migrating to the ventricle. That is a sign that tells you this is not the right platform for this particular anatomy. So you have to be able to make the decision quickly and switch out before the patient maybe start to deteriorate. Let's say there's some moderate AI now, you have to go move quickly to be able to fix the situation. I mean, any closing comments?
And I think for me, like especially the early career people over there, like our program has always advocated, especially all of you, that you should get comfortable with all the platform, because there may be cases like this where you need to take a decision and you may have to change the platform. So get yourself comfortable with all kind of platforms available commercially, and that will help you.
Any closing comments, Dr. Kinney?
No, I don't know.
Yeah.
Where is
Yeah,
she?
final question. Some operators prefer single per close. What do we think about that?
Amit, you want to comment
Yeah,
on
so
single
that's a
vertical?
great question, Dr. Moreno. Yeah, till 14 French, sometimes we do one
done,
pre-close
we are
is good
close.
enough. This one, because we had to upgrade later on, and sometimes as a as a fail-safe mechanism, and vessel size is good, we tend to do as a routine 2 pre-closes. So even if one fail, the another gonna take care of it. But in cases where the arteries are diseased and they are not gonna take 2 pre-closes, we always try to do one only. But yeah,
Okay.
till 14 French, one is good enough.
Yeah, and also people use combinations as well, right? One per close, one angioseal perhaps in maybe small arteries. You worry about cinching. So the
That's like
vessel.
in some countries it's more cost effective also,
That's right.
using one per close along with angioseal. But here we don't have that constraint, so we try to use 2 pre-closes.
Yeah.
Anu, do we have slides
I know.
from
I
Dr.
know.
Sharma?
Yeah. He's. I don't know. I think still making his slides. Back-to-back live cases. No time.
So I think Dr. Moreno, to the audience here, this is probably one of the only cases you ever see that that we need to the decision making to switch platforms that you see recorded and performed live, because most live cases, as you know, that you've watched thousands of them, Dr. Kinney has performed thousands of them, you usually just stay with the game plan. But sometimes when the game plan is not working, you have to be able to have that insight and judgment to change for the patient. And I think this is a critical, important lesson learned for all of us here today, and also hopefully for the audience worldwide, that if we try 2 times and it's not working, I think there's a saying, right? Isn't it, Amit? Is something about repeating it multiple times the same outcome is insanity, right?
Yes, you are totally right.
So you need to think about what's the right thing for the patient.
Yes.
But we,
Yeah,
in the coronary live cases,
Yeah.
right? Coronary live
Yeah.
cases, we always show it that you have a plan, but many times
And Stam,
you
yes,
change it
please
in the
have
thing.
your final comment.
This coaxiality,
Come.
the coaxiality is very important. We published this in JACC Imaging 2010. That if you have no coaxiality, the valve can move as will happen here, and then also PVL, so very important with fluoro. When we're doing this in the beginning with a transesophageal echo, we had to make sure that the valve is coaxial to the LVOT and proximal aorta before you deploy.
And Stam is absolutely right. This is even more critical for mitral tricuspid.
Yeah.
Mitral tricuspid, if you think about replacement, you cannot even deploy the valve when it's non-coaxial. They check multiple times on echo and on fluoro. So this goes to the same thing for aortic valve. I think this is a very, very important lesson learned. And that's why when we try to deploy, you saw
you
even
have
with the
slides? You
balloon
can ask them.
expandable, that you want to be coaxial.
Yeah, coaxial.
Okay, it's the end, because if you're not, and same thing for mitral valve in mouth, you can risk embolization,
Exactly.
migration, and it's much harder to control.
PVL too.
And PVL as well.
Yeah, the question I have only is if you can predict that they will not be coaxial by CT.
Yeah.
That's the question that I.
What about the
Who is here?
AI
Who else is here?
programs which are being used
Huh?
to really predict?
I thought he said he
Yeah,
didn't
yeah.
want
This,
this.
I mean, I don't think
PCI.
anybody. All these programs have the coaxiality issue. I think this will be something for the future.
Yeah.
Yeah.
Because
good.
it also doesn't happen very often. Only horizontal hearts.
Yeah.
That there is difficulty, but it's very important. And I'm
It
glad
says
we
just
determined
final-
that and we changed the valve. Because
Final question here, yes or no, does PCI first increase TAVI bleeding risk?
Answer that is no.
Beautiful.
Yep, that does not. I mean, no, sorry. The PCI, all the trials have shown once you did the PCI, outcome was not different, but there was higher bleeding rate. So,
Okay.
because point is, anytime because you are giving anticoagulation, antiplatelet therapy, and that's even you're bringing patient after 1 month, they still are higher
not there,
depth,
then we
and
can
that creates a
tell
problem. So
screening some of
therefore,
his cases
the
to
most of the data now coming or trend has been do the tower and then do the PCI. Rare case, I would say like less than 10% now, we'll do a PCI before, and it's a very high gradient, do a BAV. So that patient can be okay for next 1 or 2 months, because many times they may require some adjustment, and we saw a couple of patients, we lost them waiting for aortic stenosis, tower management. So therefore, idea should be that unless it's a severe or acute coronary syndrome with non-STEMI and have also a concomitant CAD and severe aortic stenosis, goal should be that you take care of the valve and then do the CAD management post.
Beautiful.
That's the maximum data comes from our TVT registry. So I'll just go knowing that we had a lot of excitement, but end result is great. We had to really congratulate and thank the whole team here at Mount Sinai with the experience of close to 5,000 tower. They're able to bail out in this, and as you said, there were a lot of thumbs up. Congratulations for this kind, because this is a tough case. Tough case in the sense that these are the patients rare, which happens in about 0.2 to 0.5% of cases who end up going for surgery. And of course, nobody wants to send the patient for emergency surgery. Elective is fine. This is the case if as a part of the heart team discussion, you decide, there is no calcium, although this patient has a calcium, but no calcium and should go for surgery. Nothing wrong in that, in this particular case, right?
Wonderful.
I mean, that's basically, we need to learn from every case. So what I'm going to show is some the recent publications about the tower, then FFR guidance, and ocean registry, and the new biomimetic balloon expandable tower. So surgical, if this is the latest data came from the meta-analysis about all the randomized trial, basically low risk surgery versus the tower, and basically showed what we learned. That is, in terms of the death, there was slight lowering of the death at 5 years in the tower group compared to surgery. Then you take it to the stroke, exactly identical between two of them. And then, if you take death and stroke, again, it remains lower in the tower group compared to surgery, as you can see here. Now, once you take stroke alone, it's exactly identical at the unity, and there's no difference. So basically what we learned, if you're death alone, lower with the tower at 5 years compared to surgery in this randomized trial. Stroke, identical. If you combine death and stroke, then you have a benefit of lower death, making those points lower. And this basically is we got from this study. So that is what the trial showed. I mean, this meta-analysis showed. Second was, from the notion 3, remember there is a fight TAVI, where FFR guided intervention was better compared to angio guided, and in the notion 3 they decided intervention based on the FFR, and whole question was, can you do FFR, and what is the cutoff? We know in the non-tower patients or other patients, let's say, the cutoff is 0.8. If anything more than 0.8, you can leave alone. 0.8 or below have shown to be a lower, having a higher MACE rate based on the FAME1, FAME2 trial. And particularly, if you want to do a medical management of FFR of less than 0.8, FAME2 trial after 6 months was stopped because of the benefit of intervention. So same thing, they wanted to look into this aspect, that at the patient level, that where cardiovascular mortality, MI, urgent revascularization, FFR of 0.8, above, below, and below getting PCI, or leaving medical therapy. So see, the FFR of less than 0.8 with a conservative management is bad thing. So same thing what we have for the in the non-AS patient, we exactly noted in this in terms of the coronary segment level and so on and so forth. And clearly the lower the FFR, of course we know the higher will be the event at follow-up. The second, therefore, basically was the conservative management of FFR less than 0.8 lesions was linked to higher cardiovascular risk compared to either PCI FFR of 0.8 lesion or DEFRA of FFR of more than 0.8. See, the PCI of less than 0.8 should get the PCI that we have, just like we do normally. Then Ocean TAVI registry is from Japan, and they take all the patients and they actually publish 2 papers. One was comparing self-expanding versus balloon expandable in the small annulus, and the second was based on the annulus itself only. So this is the, if you see the balloon expandable versus self-expanding, some differences, paravalvular regurgitation in the small versus standard, as you can see, is not much, slightly higher prosthetic mismatch will you expect, and the echo findings clearly that balloon expandable get an inferior result compared to self-expanding, and these are the outcome, but outcomes were not different at 5 years. So while hemodynamics are better with a balloon expandable, with a self-expanding valve, but does not translate into the to the outcomes. That is what we learn, as you can see here. Identical. 5-year outcomes are identical, although initial hemodynamics are better in the self-expanding versus balloon expandable valve in the small annular. The second one was hemodynamics of the latest valve, and basically they compare SAPIEN versus Evolut, and same thing, Evolut is a self-expanding. So hemodynamics better, mean gradient more than 20 will be higher in the balloon expandable versus self-expanding. So same thing, the kind of a question which was in the previous slide, and here they just went to the latest valve. And latest valve outcome again at 1 year identical. The valve degeneration was slightly different mechanism, but overall it just shows that if you see on the left side, if the annulus was less than 430 or more than 430, and comparing SAPIEN versus Evolut, the earlier data was a small valve on 20 millimeter only, and here you can see the very interesting finding. That is that if you have self-expanding valve Evolut, and if you compare 430 small annulus versus large annulus, and you can see here, large annulus actually have a higher bioprosthetic valve dysfunction. Now, if you go to the balloon expandable, the balloon expandable have a lower bioprosthetic valve dysfunction in the larger valve. So little differences overall, just to say that we have to follow these patients and so. Then they showed some data of our SMART trial. That what happens, we know hemodynamics again self-expanding better than balloon expandable in every aspect, every parameter of the self-expanding, but our hemodynamics, but we know 2-year data, no difference. In the Ocean TAVI, we have 5-year data, no difference in the outcomes. Now then there is a new valve, biomimetic balloon expandable valve called AVR. And this has taken a lot of interest because this is done by single bovine leaflet compared to current TAVR valve. They have 3 leaflets. It's a single one, and hopefully it have a better hemodynamic. That is the whole concept of this valve. But still, the outcome seems to be the short studies, the small have been done, showing that better effective orifice area and lower PVL in this valve. So seems to be a little exciting for the short term. That's what we are going to see more and more about it. So let me just sum it up. Meta-analysis is a randomized trial for the TAVR versus SAVR for low risk shows similar stroke, but lower death and stroke. Second, decision to PCI based on FFR cutoff of 0.8 is appropriate and predicts subsequent MACE rate, so that even in the TAVR patients, AS patients who are going TAVR, had a TAVR or did not have or will have TAVR, decision with the FFR is similar what we do for the non-AS patients. So 0.8 cutoff remains. Then Ocean TAVI registry have shown the better hemodynamics with the small annulus, bigger annulus, and with the self-expanding valve. But there is no outcome difference even at 5 years. And the biomimetic balloon expandable valve shows some better the hemodynamics. Then the results of the meta-analysis of the low-risk AS patient comparing TAVR versus SAVR showed the following, except the higher incidence of stroke in surgical group, lower incidence of death and stroke in TAVR group, lower incidence of death in TAVR group, and similar incidence of stroke in both groups. Clearly, the A is wrong because this is identical. The stroke was identical. Then following statement is not true about the Notion 3 trial, about the FFR. FFR of 0.8 predicts bad outcome. Significantly higher MACE rates with a TAVR with FFR of more than 0.8. FFR of more than 0.8 is good for no PCI, and FFR guidance should be routinely used in decision about PCI in AS and CAD patients. Clearly, B is wrong, that more than 0.8 does not have a higher MACE rate, has similar rate. So with that note, we'll just stop our presentation today, and we'll take any other questions. Pedro, if anything left now.
Nothing but the thank you for our team. Thank you for the audience for this fantastic case. Remember, it will be available as soon as this afternoon at ccclivecases.org. Our next structural heart like cases is going to be on March the 10th, second Tuesday of the month at 9 a.m. See you there. Thank you so much.